Okay, everyone, we're at 45 participants in climbing, so I'm going to get started. I'd like to thank everyone for joining us for this, our final Institute for Health Equity Research seminar for 2022. Delighted that you could all join us. My name is Lynn Richardson, and along with my colleague Carol Horowitz, I co-direct the Institute for Health Equity Research. And I'm delighted to introduce our speaker for today. Dr. Mary Catherine Beach is a professor of medicine and core faculty of the Berman Institute of Bioethics and the Center for Health Equity at the Johns Hopkins University. Dr. Beach's scholarship on respect and relationships in healthcare encompasses both empirical and conceptual dimensions. Most of her more than 175 published articles focus on improving communication between patients and clinicians, the importance of clinician attitudes toward patients to enhance the quality of healthcare, and on how clinicians use language in medical records to convey their attitudes toward patients. Her research has been funded by the National Institute of Mental Health, the National Heart, Lung, and Blood Institute, the National Institute on Drug Abuse, the National Institute on Minority Health and Health Disparities, and the Agency for Healthcare Research and Quality, as well as the Robert Wood Johnson Foundation and the Greenwald Foundation. She's won numerous awards for her scholarship, her mentorship, and is an elected fellow of the Hastings Center. It is my great pleasure to introduce Dr. Mary Catherine Beach. Please. We're all waiting for your presentation.
Thank you. Thank you so much. I think maybe the most important part of my bio is that I am a graduate of Mount Sinai Medical School and did my internal medicine residency there and finished in 1998. I moved away to Baltimore for 3 years in 1998, and then I ended up just staying. So that's how I wound up here. Okay, I'm going to share my screen. All right. So the topic of today's presentation is stigmatizing language in patients' medical records. This is something that I've started working on over the past, I would say, 7 years, kind of slowly in the backdrop, and it's gained a lot of momentum. And so I want to present to you kind of how I discovered this and then what I've done with it, as well as sort of what's coming out now from other groups around the country in terms of stigmatizing language and some of the momentum that's gotten in terms of coming up with health system solutions. So I just also want to acknowledge that there's a lot of my colleagues and friends who have participated in this work who are listed on this slide, and there's probably many others. Okay. The slide is not advancing. Oh, got it. Okay. So I'm going to start just talking about like how we might think about stigmatizing language in medical records and tell you the story about how I started noticing it. So there was a whole period of my life in around 2006 through 2015 where I was really working a lot on sickle cell disease, because my interest in respect, and I felt that people with sickle cell disease were treated badly and stigmatized in healthcare. So what I wanted to do was come up with a measure of pain management quality and realize that there weren't very many measures of pain management quality. And so we went into people's medical records and we started to try to figure out like what level of pain were they having and how much medication was given, and then when were they reassessed and what was their level of pain then, and was the medication changed, et cetera, and were all these pain management guidelines followed. And what I think we noticed once we were like reading the records, trying to figure out and pull out, pain scores and doses of medications, was that there were 3 like overlapping themes that we discovered that really conveyed a very negative attitude towards the patient. And the first was casting doubt on the patient's reports and experiences. In this case, mostly it was doubt on pain, about the level of pain someone was having. But then there was other language like that would perpetuate negative stereotypes and blame patients for their symptoms. So I'll give you a couple of examples of these just to give you a flavor. The way that clinicians, I felt, were casting doubt on the patient's reports of pain were quite sometimes obvious. I mean, people would say that the patient has narcotic-seeking behavior, but then there were all these indirect ways that it would happen. So a clinician might juxtapose the patient's report of pain with some kind of discrediting observation, like reports 10 out of 10 pain, but labs are stable, even though we know that stable labs don't mean that someone isn't having 10 out of 10 pain, but nevertheless, there certainly seems to be that implication there. They would also use quotes, put someone's words in quotes, reports pain medication is, quote, not enough. And that's what sometimes people will call scare quotes, indicating that you should doubt whatever's in between the quotes. And then the use of discrediting verbs or adverbs. So, someone could say he claims he still has pain, insists her pain has not improved, and that kind of thing. In terms of negative stereotypes, I found that there was sometimes some clinically irrelevant information that people would put in that didn't need to be there. That he was hanging outside of McDonald's, or he's observed to be snoring loudly. These are things that are potentially going to create a stereotype or some kind of negative feeling on the part of someone who reads it. And then they would also quotes would be used in a way that I think conveyed as low education by quoting poor grammar or that kind of thing. And then there was the existence of blame, where people would highlight non-adherence in a way that suggested judgment. So, not wearing mandatory oxygen, the word mandatory didn't need to really be in there, calling people uncooperative, refusing oxygen for a, quote, short walk, and that kind of thing. So after we did that study, focused in that one area, I started to just notice it when I would be reading notes in clinic. When I would be seeing patients or precepting residents, I would look at what the notes were saying, and I would think, well, that's not just happening in sickle cell disease. There's actually some of those same things are happening just more broadly. And we, although we never published that framework for sickle cell disease, we then went on and did this study where we kind of did a qualitative analysis of medical records in internal medicine, ambulatory practice, and characterized language as follows. Now, I should say at the outset that these categories are not perfect. They're kind of overlapping. Anytime you come out with a quote, someone will argue with you and say, or a piece of text from a record, someone will argue and say, well, is that really stigmatizing? Or, well, I could see why they would write that. So it required that we do a lot of just, gestalt. We're going to put this out there. We're going to acknowledge that, maybe it was okay, and maybe the person, didn't mean it to be stigmatizing, or it didn't reflect bias, but we just need to put something out so we can look at it. So there's, again, inclusion of details that don't really have a clear clinical significance, that depicts the patient in a negative manner as difficult or unpleasant. There's stereotyping where people are quoting incorrect grammar, unsophisticated terms, or African-American vernacular English. There's disapproval. So highlighting people's poor reasoning or self-care in a way that conveys that they're unreasonable. So in this case, he reports that if she were to fall, she would just lay there until someone found her. The clinician if you read the whole note, doesn't really think that's a good plan and is trying to convince this person to do something different. And then, the patient who's adamant he doesn't have bladder cancer because his bowels are working fine, that really has nothing to do, or prostate cancer, excuse me, this has nothing to do with the fact that the patient could or couldn't have cancer. And so I think it's highlighting the fact that the patient doesn't really know, and yet they're still insistent that they don't have prostate cancer. And then again, all of the undermining credibility that I spoke of before would still happen outside of the sickle cell disease context, where he insists the pain is behind his knees, claims that nicotine patches don't work for him, that sort of thing. The other thing we did in this paper, though, is that we actually noticed that there were a lot of positive things written about people too. So sometimes there would be like a compliment, like, you'll see a lot in medical records. Patient is charming, pleasant, kind, delightful. Approval, where the clinician is really pleased with something that the patient has achieved, or makes it clear that they've enjoyed interacting with the patient. So, she's enjoyable to converse with on many subjects. She struggled with quitting, but she's quit tobacco for 1 week with exclamation points. That I've seen a lot, where the clinician is quite enthusiastic and excited that the patient has achieved something. Another positive theme we found was when the note is personalized. So these are details about the patient as an individual. She's a songwriter, and she also sings strong faith in God and believes he has blessed her, continues to keep her strong, enjoys walking with her fiance and her dog named Scout. It's hard to read something like that about a person and not be like really struck that this is a person. And whereas I think, when we write these intensely clinical notes that are stripped of someone's feelings or family or what they care about, it's easy to forget that we're writing about a person. Whereas if you write something like this, it's impossible to forget that. And then this other positive theme we found, which is really more just a way of mitigating a negative theme, is minimizing blame. So when someone has an unhealthy behavior, there are better ways to write it. And we're always trying to find really good examples of where someone writes something about something that might be stigmatizing, like non-adherence, but they write it in a way that really respects the dignity of the patient. So in these cases, these were about she's not been checking her glucose because she lost her glucose monitor. She's not been taking iron because it makes her constipated. There was another one that was saying, he reports, I fear that, the medication, the complexity of the medication regimen is just making it too difficult for him to remember it. So there's like lots of ways that the clinician can try to have empathy or understanding of what the patient's behaviors are, and they can convey that in the record. So the thing that we did do with the sickle cell disease stuff is we looked at the impact that language might have on the perpetuation of bias. So here, what our research question was, okay, we're looking at this language, we're second guessing ourselves all the time. Like, is that stigmatizing? Well, let's ask the question. So what we did was we developed these vignettes where we could test if we put stigmatizing language in the vignette, is that associated with the subsequent clinician's attitudes towards the patient and then the management of the patient's pain. So we're really trying to get at the impact of the language. And just as the vignettes were a little longer than this, but this will just give you an example where the neutral language one would say, he still has pain rated 10 out of 10. His girlfriend is by his side, but will need to go home soon, which was how we rewrote what we had actually found in a record, which is he's insisting that his pain is, quote, still a 10. His girlfriend is lying on the bed with her shoes on and requests a bus token to go home. So we randomized internal medicine, emergency medicine residents, and medical students to get one or the other, the stigmatizing language or the neutral language vignette. And we used an existing attitude score where more positive attitudes are higher and more negative attitudes are lower. And we saw that when we asked these questions of the people who read the vignettes, there was a significant difference with much more negative attitudes towards this hypothetical patient when they read the stigmatized version. We then asked what doses of pain medication they would give, and with on this score now that we did more aggressive at the top to less aggressive at the bottom, we also found that there was a significant difference between the neutral and the stigmatizing language condition. It's funny, the Hopkins wrote this study up in one of their newsletters, and it's open to the public for people to comment. And the first comment on the study was like from, a patient and who basically said, like, did you have to do a study to prove that? Which I thought was pretty funny and fair because it does seem like the obvious thing. Like, of course, if we're going to put this language in, it's going to have an impact. Also in response to this paper, Danielle Ofri wrote an article in Slate magazine about how your medical chart might be biased. And what she said when we were talking and what she wrote in the article was that this language that we use could be considered dog whistling because we are actually speaking to each other in a way that isn't always 100% obvious. Like not everybody can hear it, but we can hear, like we clinicians kind of understand what the implication is of writing things in a certain way. And I thought that was a very insightful comment on her part. So now coming around to one of the themes that I showed you in both the sickle cell disease and internal medicine context is this idea of like, do people get believed? And is there language in records that shows whether or not people get believed? And I became really interested in this because I think it's actually so important. There's so many articles coming out recently. There was just one, I think, in the New York Times on gaslighting, women feeling gaslit when they go to the see a physician. In this case, this was the Chicago Tribune. Someone was quoted as saying 9 times out of 10, I was completely brushed off. If there was ever a book on medical racism, it should probably just be called They Don't Believe Us. And actually, the language in the records, when I was presenting it once, someone pointed out to me, an ethicist, that this is really a matter of ethics in the sense that it's a type of epistemic injustice. Which is called testimonial injustice, where a speaker receives an unfair deficit of credibility from the hearer owing to a prejudice on the hearer's part. And once someone pointed that out to me and I had a chance to read this book, I realized how profoundly important it is. That's something I had never really thought of before. And it made me reflect back on a bunch of studies we've done where when we did work on what it means to be treated with respect, there were African-American focus groups where people would say over and over again, you know your body. When you come in, you know yourself, or you can't not tell me there was nothing wrong. I feel like that's disrespect. And someone said, we know what's hurting, whether they want to believe us or not. And this was just people in the community. These were not people with sickle cell disease. So this is like going way beyond. And then you look and you're like, oh yeah, actually this language about disbelieving people, that exists in the medical records and we can look for that. So we did that actually. We tried to figure out how are we going to measure this language of disbelief that might reflect testimonial injustice in the record. And so our first attempt at it, I think, was a little bit crude, but we wrote it up in this paper and I'll describe it a little bit. So to back into another field, because one thing I've learned from doing this work is that I have had to find collaborators who understand things that I've never studied, like philosophy. I am in the Berman Institute of Bioethics, but I'm not a philosopher. So, all of that stuff on epistemic injustice was new to me. Once I started looking at text and records, I realized I need linguistics. Like I need to be able to describe why, when I read this, do I feel this way? And that's what the field of linguistics can do. In any case, so I partnered with a linguist who talked about then epistemic modality, which is essentially how we use language to encode whether something is likely to be true. So what we did was we looked at all of the notes written in 2017 at an ambulatory internal medicine clinic. We used NLP to identify 3 linguistic features that might cast doubt on the patient's report. The first is evidentials, the second is judgment words, and the third is quotes. And then we examined differences in these features by race and gender, and we used mixed effect modeling to account for all the clustering that exists. So what are these three things? Evidentials, well, you know what quotes are, but evidentials are a grammatical element that indicate the source of one's knowledge. So if you say, it will rain later, that indicates certainty. If you say, I heard that it will rain later, you're attributing that information to some other source. And so you're declining to endorse the information. You're not saying it's true. Now, we use evidentials all the time in medical records, and I don't think that they cast any explicit doubt on the truth of the information. When we report what in the record, what a patient has told us, we'll write the patient states or the patient reports she's not been checking her sugars. She reports that she has all of her other diabetes supplies. And then usually, and here's my point in looking at this, I don't think it's wrong to do that. I think that helps us diagnostically reason through where we just get different sources of information. But I had this idea that maybe because it feels just weird from a narrative standpoint to continue to repeat that we drop it at some point. So we might say, patient reports she's been checking her sugars because she has no lancets. She has all of her other diabetes supplies. She takes her insulin every day. She reports, she is 100% compliant, and we don't keep repeating the reports. So the theory in this was that the more evidentials that exist in a note might mean that there's like more declining to distancing yourself from that information, declining to take it on as something true. Judgment words were things I showed earlier, like she insists that the pain is in her knee. She claims she'll, if you say she says she'll pass the exam, that's an evidential. If you say she claims she'll pass the exam, you're not just giving an evidential, you're explicitly saying, I actually don't think that's true. So we came up with a list of words that we thought might reflect that kind of judgment. And then we looked for quotation marks. I think this is a little bit problematic in this sense because I do think quotes are used when people's words are doubted, but I think they're, as I showed you earlier, they're used for a lot of other reasons. Sometimes they're used for good reasons because it's important to know exactly what the person said. Sometimes I think they're used just to mock someone, which is obviously terrible, but it's not casting doubt on what they said. So this is like slightly imprecise, but we looked at it anyway. And so we did this in 8,000 notes written by 164 clinicians about almost 2,000 patients. And this is a big table. So focus on what's in the red box. So if we looked at evidentials and we looked at the number of evidentials, we found that on average, in an unadjusted analysis, there's 1.5 more evidentials in notes written about Black patients than notes written about white patients. That difference was markedly reduced when you adjust and account for clustering of notes within patients and patients within clinicians, but it's still significant, statistically significant. And this was true of both of the other outcomes. So there were more judgment words in the notes of Black compared to white patients, more quotes in the notes of Black compared to white patients. And it was significant both after unadjusted and after adjusting for the clustering. So what happened next? So we published that paper maybe 1.5 years ago, and around that time, there was another group in Chicago that looked at that did something similar, and they published a paper in Health Affairs called Negative Patient Descriptors: Documenting Racial Bias in the Health Record. And so what they did was they looked at a series of words. There were about 15 altogether. They included like non-adherent, aggressive, agitated, angry, challenging, combative, non-compliant. You can see the list is on the slide. The most common words that they reported were non-adherent, non-compliant, and refuse. So that's what they That's what they were looking at most commonly, but they looked for all of these words. And they did this in almost 20,000 patients. They all happen to be patients tested for COVID because, you know, in the wake of the pandemic, everybody was pulling together data sets. And so somehow that was the inclusion criteria to be in the data set. And this was in Chicago. The population was in this data set were 60% Black and 30% white. And it included 40,000 history and physical notes written over almost a 2-year period. And what they found was that there were a significantly higher odds of a patient, this was a patient level analysis, not a note level analysis, significantly higher odds of a patient having one of these negative descriptors in their record if they were Black compared to white, and also a significantly higher odds if they're Hispanic or Latino compared to non-Hispanic white. Another paper that came out of Boston, and this was published in JAMA Network Open. This paper looked at 49,000 admission notes in the year 2018, about almost 30,000 unique patients. This was a mostly white sample, 64% white and 8% Black, almost 2,000 clinicians. And what they did was they focused on a series of words that where there were about, I want to say like 50 different words that were meant to be disease-specific stigmatizing language in diabetes, 3 diseases, diabetes, chronic pain, and substance use disorders. And those words were like words like controlled, because the language guides around talking to people with diabetes, and where people have done focus groups of people with diabetes, have felt that the word controlled or uncontrolled, I mean, it feels terrible because people can be working very hard and then, you know, they'll be called uncontrolled. And so people don't like it, which is understandable. And I can see why we could move away from that language. And the only thing is that it's still very normative, and it's normative in the medical record. So they did find that there was a good amount of that. So what they found when they did this was that notes written about Black patients had a 0.67% greater probability of stigmatizing language. So this was like the absolute difference in probabilities, because the overall, and this was statistically significant, the overall probability of having a note written with one of these words in it in their study was actually quite low. And so a 0.67% increased probability, if you look at their prevalence, probably the odds ratio there was more around like 1.5, whereas the Chicago study was like 2.5 was the effect of race on stigmatizing language. So not terribly different, and in a different context. One thing to note, though, is that the most common words that they were found to be different. So this was a snapshot of part of one of the figures from their paper. If you look at the words, these are this is the odds ratio, and when the bar moves to the right, the estimates move to the right. That means that there's a higher odds of a note written about a Black patient having that word. If it moves to the left, it's a higher odds of a note written about a white patient having that word. And so most of the words that were most significantly more common in medical records of Black compared to white patients were related to accepting and following medical advice, and then glycemia, like the words controlled and uncontrolled. So that I always feel like you have to be able to really compare these studies and understand what we're finding. You need to dig into them deeply so that you can really think carefully about what the stigmatizing language is that exists, because I think that will really help us come up with different solutions. So what do we think is next? That's where I sat, I guess, maybe about a year ago, where, you know, I had done this work in Testimonial Injustice. These papers were coming out about these negative descriptors or these negative words. And so I was thinking, all right, what are you going to do next? And I thought, we're actually, partly because of the the negative descriptor papers were using like lots of different words, and we're mixing kind of non-adherence words with disease severity words. I thought I want to try to get more nuance about this. And a lot of the language that I found when we did that qualitative paper, there wasn't a specific word that was used. A lot of it was, this like really subtle microaggression where, it was like something was said about the patient. It didn't need to be said that way, but if you were reading it from the outside, you wouldn't be 100% sure that that wasn't an insult. But the thing about machine learning, and the thing is that you need to be able to have two people agree to get annotation correct in order for natural language processing to work. And what we found is that we had so much trouble getting any two people to agree that a sentence in a note was indeed stigmatizing, or shouldn't have been written. And so I feel like I kind of like just set that aside, and I thought, okay, this is important. I actually think this is maybe more important than, finding these words, but I don't know how to get at it. And so I feel like this is a really important frontier for us, maybe someone who's listening, to work on it and make progress on. But what I did think would be kind of easy for us to start doing was to improve these text search methods. So I thought we should take all these words that people are looking for and calling stigmatizing, and we should conceptually sort them out into different types of stigmatizing language. Then we should make sure we use natural language processing to at least identify when the word is being used in context. So like the word adherent, if we say someone is adherent to their medications, that's different than saying the skin was adherent to the bandage or something. So we need to be able to have a way to kick out the examples of words used out of context so that we make sure we're measuring it accurately. So we did a little bit of that. And then we also thought, let's look across specialties because we don't really know how these words are used. And I think there's potentially some differences there. So this is what I'm going to show you next is kind of like what we're working on right now. So it's not exactly finalized, but I'll give you a sense. And so the conceptual analysis of stigmatizing language went like this. Of all the studies I showed you, we pulled out a bunch of words and we said, okay, there are words that are negative, aggressive, so long as we're not talking about like aggressive treatment or aggressive disease. Yeah, agitated, angry, argumentative, those kinds of words. Then there's positive words. And I thought, well, no one's really looked at those yet. So those are pretty low-hanging fruit. We can look for lovely, charming, pleasant. There's words about not following medical advice, which those are stigmatizing because when clinicians read a note about a patient who hasn't been following medical advice, they might think more negatively about that person. But sometimes people aren't following medical advice, and it's a relevant thing to put in the medical record. And so I'm sort of struggling with what do we do with that category. But I thought, let's just pull it out and let's look at it separately and maybe try to look at it in different ways and think more carefully about what do we do with, how do we write about people not following advice? And I also thought it would be important to characterize when someone is writing about whether they're following advice or when they're not following advice as like two different separate things. And then a bunch of words around undermining credibility, as I showed you, around testimonial injustice. So what we did, the intent was not for you to absorb any of this, but just so that you can kind of see what the steps look like in this process. So what we do is we read a bunch of notes, we find those words, we read a ton of notes, and we start to see how are they being used. One thing that I didn't realize was that there's a whole bunch of non-specific language around adherence, like we know we are going to encourage adherence. We discussed adherence. If we if he's adherent, if, all of this hypothetical stuff or general stuff. So what you have to do is for each word that you're trying to study, you have to annotate it into different categories. And this just basically is trying to show you what the annotation guide for a series of words around adherence or compliance would look like. And then, we have a computer program where you go in and it pops up the text around the word, you look at the key word, and then you categorize it into one of the categories that you want to capture according to the annotation guide. Again, not intended for you to absorb any of this. It just basically shows you then what you can do is you can take each word and you can see how many instances of that word exist and how many instances get categorized as in the different buckets that you were annotating in. So if we looked at, for example, the word aggressive down at the bottom left here, you can see that about 5,000 or 4,700 times that word just gets excluded because they're talking about aggressive disease or aggressive treatment. Some of the time it gets included, and then, there's some other stuff that we probably don't care about. So here's what we are finding so far. So far we've looked at 109,000 notes across 3 specialties. And so what the first column here is all specialties. So that's all together right here. And you can see that there's a fairly big, there's 13% of notes have a positive descriptor of the patient. Much fewer, many fewer notes here have a negative descriptor. So like 4% of notes, and only 1.5% of notes have an explicit marker of doubt. Because here we're getting much more specific than in our previous study. And the odds of these words being used in notes of Black compared to white patients, there's a much or significantly 6% lower odds, but statistically significant, of the word being used, a positive word being used. No difference in one of those negative words being used, but a 40% greater odds of a marker of doubt being used in the notes of Black compared to white patients. And then, we're looking across these specialties: internal medicine, OBGYN, and surgery. And it turns out that the underlying prevalence of these words differs a lot by specialty, because positive things seem to be written, about 15% of the time in internal medicine, 5% of the time in OBGYN, and 25% of the time in surgery. So there's a big difference there. And part of that is what accounts for the fact that, there's more of examples of this. So this ends up being statistically significant in surgery, and it doesn't in OBGYN. But in any case, it's sort of consistently true across the 3 specialties that there's less positive language in the notes of Black compared to white patients. And there's not across any of the specialties a significant difference in the use of those negative words for Black compared to white patients. And you can see that there's even lower prevalence of the use of negative words in the OBGYN and the surgery cases. And again, some differences in the use of credibility doubt markers for across specialties. We also looked then, at this adherent and not adherent, and we found that in all specialties, with some exceptions, you can kind of see the words adherent, or the patient is marked as not adherent more often if they're Black compared to white, and they're marked as adherent more often if they're Black compared to white. So that was something interesting. It kind of makes us think that there is, it reminds me of a study we did where we looked at implicit bias against Black patients related to adherence. Like, is there a bias thinking that Black patients are going to be less adherent? And the stronger the bias against patients, the more clinicians talked about adherence in the visits with the patients. So I think there is implicit bias around adherence and whether people are adherent or not. as evidence in the fact that it's mentioned more often, whether it's there or not, whether it's positive or negative. And then, and I don't think it's, I think we might be getting exhaustive data, but we did also kind of look at the more acceptable terms to describe adherence, like adherence, adherence, and decline, as opposed to compliance and refuse. And we found that both of them were used more often, and there were some differences, like OBGYN is not using, and like our hospital, at least in 2017, was not using compliance and refuse. They had like completely taken to adherence and decline. So anyway. Okay, so just to summarize and then offer some reflections, and then really looking forward to your comments and questions. Language in medical records may reflect biases, and these biases might be unrecognized by the authors. I think this language does perpetuate stigma that influences subsequent providers. And I think it reflects and perpetuates testimonial injustice and other types of structural and interpersonal racism, especially for African-American patients. I do think that the existing studies have some important limitations. I still think it's that this finding is accurate, but I think we just want to dig into it more carefully. In terms of measuring stigmatizing language, I think, as I mentioned, most of it is subtle. They're microaggressions. It's difficult to pick up. Stigmatizing words text searching with NLP to determine context is the best method I've seen developed to date. But the overwhelming majority of words that were considered stigmatizing in some of the previous studies relate to accepting or following medical advice. So we have to think carefully about how we want people to write, how we want clinicians to write about that in a record. And if it's the case that there is more non-adherence among Black patients for reasons more related to structural racism, like mistrust in the system, not being able to get medications at pharmacies, not having medications covered by insurance, all kinds of possible reasons why that might be true. And if it is true, then, what do we do when we write in a record and we know it's going to be stigmatizing? So we can think about that. I think we should sort out and measure the different types of language, these conceptual types of language differently. And I think we should account for differences in specialties when we measure. In terms of recommendations, I would say for clinicians, I think they should stay aware of and avoid including language that reflects personal frustration. I think a lot of the stigmatizing stuff I see seems like the clinician is just irritated, and maybe some more emotional awareness would help. I think we need to strive for testimonial injustice, which I think means becoming aware of this as a racist idea and trying to account for that. I think that we need to think really carefully before we use quotes, because a lot of the stigmatizing language I see is signaled with the use of quotes. And my partner and I just published a paper in Annals that's like an advice, like what do we do when we want to quote people, and when should we and when shouldn't we quote people? So this is just like a thought piece. In terms of possible solutions for health systems, I think, we can always think about clinician education. Everybody says that's like the least effective quality improvement method, but I do think that because this language has been unrecognized for such a long time, it is my experience that when I talk to a group of clinicians, they are often very insightful and thoughtful about it, and will say, oh yeah, I realize like I do write things like that and I probably shouldn't. So I don't think we should give up on clinician education. I think if we're going to do it though, we also have to it has to be thoughtfully delivered so that we're not telling people that they shouldn't write things, that there's no alternative to write. Like we need to give people alternatives, ways of writing things that might be stigmatizing when they're sort of not, you're in an emergency department and there's a huge conflict and it's going to get put in the medical record. It's going to be stigmatizing. So we're trying to help people write about things in a way that's minimizes that. think audit and feedback is interesting. I mean, I think, we develop these NLP ways of measuring it. We can look for it and give reports back to different units and clinicians, but I think that the measurement has to be really good in order to do that. I think I know Epic is working on this, stigmatizing language text searching, but it's not going to have NLP capacity. And right now, at least the last time I met with them, they were using that list of words from the Chicago study. So it includes words like non-adherent. And I'm worried that if we give clinicians back a report that says they use stigmatizing language because they use the word non-adherent, that they're going to get irritated and it's going to backfire. People have suggested auto correction. So, you might be writing a note and you might write, the patient is adamant that they don't have whatever, and something will pop up and tell you maybe you should write it a different way. I think that's going to annoy people, but I think it's possible if we can figure out which words we would really want to pop that up for. And I think we should create a culture of accountability where we all recognize that this is there and we stop ignoring it. I tried to call one of my papers hidden in plain sight because I think it has been sitting right in front of us for a really long time, the way we write about people in very disrespectful ways. And we just haven't noticed it. Like I hadn't noticed it for a long, long time. Now that we are, I think we can start to all hold ourselves and other people more accountable, and while we're training this. So that is it. I'm going to stop here. I look forward to hearing from you. I will probably stop sharing my screen now. And I'd like to hear your comments and your questions.
Thank you so much for that, Mary Catherine. If you have questions, please put them in the Q&A feature on the Zoom, and we already have several. So the first question asks, have you looked at psychiatric notes at all? Psychiatrists make judgments of behavior that may influence diagnoses more than other specialties, and so potentially could be even more liable to biased language. Have you looked at psych notes at all yet?
No, I haven't. And I haven't because just for the reason that you point out, because it's a more complicated, analysis, because there are, I was looking at testimonial injustice, and, there might be reasons to distance yourself and not just write that, if somebody's having a psychotic episode and the things that they're feeling are happening to them are not happening to them. And so, it makes a lot of sense to put it in quotes or to distance or to write about it in a way that suggests that it's, that's not actually truly happening. So I was shying away from it first for that reason. And I think now just because it's not my specialty and I feel like I need someone who's in that field to help us figure out what's a good and bad way to document.
Yeah, I think, as you know, we've started very similar work here at Sinai, and it's already clear to us that there are going to be some specialty-specific aspects to this work.
Yeah.
And I like the dog whistle quote that you had, because there are, I think, in each specialty, some code words that may seem quite benign to people who are not in the specialty that have a very well understood meaning, and so we're going to have to deconstruct all of those as we move through this. The next question is, I'm assuming the quotes in EHR may also have been developed as a practice to do with, quote, giving a voice, unquote, to patients. How do we distinguish between giving voice and bias in the use of quotes?
I mean, it's a great question, and that's what we tried to get at in that editorial we wrote about, do no harm when you think about quoting people. Like, there are very good reasons to quote people. We are all taught to quote people. And what's someone's chief complaint? It gives a voice to the person. I think, part of the problem is that there's been a drift in society, never mind just in medicine, in society, the use of quotes has changed. So like originally quotations were meant to capture something accurately without reinterpreting it. So it's supposed to be more accurate because it's from the original source. That's a very benign, laudable reason to use quotes. The problem is like we're now using quotes when they're scare quotes where we're insinuating something with the use of quotes, and we're not always making it clear what we're insinuating, but we're insinuating something when I think what we recommend is use quotes if it's important for the person reading it to know what the patient said. So if somebody described their chest pain as crushing, I might put that in quotes because it's a context clue that's really helpful. I have now started just thinking of avoiding quotes altogether that don't have a very good purpose simply because people are now reading them and interpreting them in that negative way. But I totally agree that it's hard to say.
Okay, next question. Curious if in your study you had the opportunity to field alternative language that was driven by community members and participants.
Great question. We have not, and we would like to do that. It is becoming more and more clear to me that alternative language is like what we need to start exploring now.
Thank you. A comment actually from one of the participants in our own work group on this, asking for your thoughts on regarding solutions, increased awareness and utilization of note templates to mitigate stigma.
Oh, yeah. I mean, people have said that, like, should you use more, yeah. I am struggling with it because I think that you lose something when you lose a narrative. And yeah, you're right. If you had a forced entry for, and like we do a lot now for nursing notes, you're going to lose some of the stigmatizing language, but you're going to lose other things that you want. So it's a challenging one.
It is. It's really a balancing act. The next comment from the audience, I'm curious how this might apply to things like body size, where people may find typical mainstream medicalized language such as obesity stigmatizing and have other preferences for how their weight/size/BMI should or should not be referred to. Any thoughts about this issue?
Yeah.
Are you using any words or any of these words in your list of stigmatizing language?
No, we're not, and we could for sure. When there was one study, and I felt like I didn't have time to get into that part of it, but published it within the open notes community, where there were patients, about 10% of people who had read their note felt insulted or disrespected. And they asked people, like, what did you feel disrespected by? And, obesity is, the word obese is high up there in things that are, that feel terrible to read about yourself. So I think, using, even though it's a medical term, and the clinicians may have no ill will in using it, and there's a lot of things in that category, denies, like someone denies chest pain. That's a word we use all the time. We have no negative feelings towards someone when we write that in the note. And people feel like they've been questioned. And so I think we have to figure out which words do we use that upset people that we could change. And obesity is one of them.
Yeah, I think this again highlights why it's so important to bring patients into this work, because we really need for them to give us the language that we should be using. And I as I've said before, and I think many of us, I was actually taught to use the terms claims and denies when I was taught to document in the medical record. Those were the words I was given to use. And so you're
Well,
right.
we're
We think
still
about
taught.
it, we use
Yeah.
it without even thinking
Right.
about the way it's received by patients who are reading it about themselves.
Yeah.
But I do think we can change it. But I agree with you. I think it's used all the time with really no intended disbelief.
Right.
But it is very unfortunate that that's the language that we were taught. And we could talk some other time about why we were given those words to use by the people who
Right.
educated us.
Right. Yeah.
Have you looked at how this language connects to outcomes? Is the next question.
Oh, great question. We have not. And I think I find that to do it in an observational manner is so challenging because there's so much, cause, effect, cause. But I think that the outcomes you could theoretically, like the experimental design, which is a hypothetical person, and like, what would you give, what dose of pain medication would you give? Or, somebody comes in with a headache and, it's a quote, worst headache of their life in quotes versus, someone and like, what tests are you going to order? And so, you could sort of start to get at how it changes outcomes. But if you looked in a medical record and said, are these words associated with worse outcomes, you might find it because it could go either way, directionalities. But yes, I still think it would be worth looking.
Yeah, I think it'd be interesting to look also. What are some of the ways you've seen this be successfully integrated into medical education? And they reference a neat piece about a narrative medicine workshop.
Oh,
for this book.
there was a great workshop at the Society for General Internal Medicine this past year by some people at Pittsburgh about educating around the stigmatizing language, both in written records and when people are presenting orally to each clinicians to each other. I think yes, that we should be. That's going to have to. That's part of changing the culture and creating accountability is going to be giving feedback to people. And I think this group at Pittsburgh did a really nice job of that workshop.
Some institutes have implicit bias training for physicians. Do you think it might help to have a component for stigmatizing language in the training? Because I, as a clinician, would be open to reflecting, but I also need potential alternatives.
Yeah.
Would love to hear your thoughts on this.
Yeah. I mean, I think I have had very open, positive reactions from clinicians when I talk about this. And I feel like it is one of those things where people are reflective about it. And yes, people like, there are some things where you don't need alternatives because you could just look at that word and say, like, I should write that.
That's right.
I don't need to describe someone in that way. But then there are definitely things like if we're going to go into the, how are we documenting around following advice or not following advice or accepting advice? I think we definitely need alternatives.
Is there a way in your NLP sorting and analyses to distinguish between language that might be intended to be, quote, positive or, quote, negative when used to describe someone based on their perceived gender, such as the use of lovely or delightful? Yeah. Is that really positive? That was my edit at the end. That's not in the person.
I mean, no, you're absolutely right. I mean, there are definitely people that are like, why is that in my record? Like, what does that on earth have to do with my, and yeah, they're used in notes of women a lot more than men. The words are gendered, but they're used in both. And I don't know. I mean, do I think some people have said, like, I've heard debating around, should we get rid of those positive words or should we keep them in? So I'll just say it's worthwhile debate.
It's worthy of discussion. Well, we have reached our time. There are actually still many questions for you in the Q&A. I think you've given us all a lot to think about. I want to thank you for coming to share your work with us, and look forward to continuing the conversation as we also take this on as an initiative of the Institute for Health Equity Research. I see lots of applause now
Thank
floating
you.
into
I've never seen that
the field.
applause feature, but I'm really touched and
That
I love it.
we have
It feels
top-notch
like I'm
AV people here. Yes, it's great. And thanks to all of you who tuned in to listen to us. Again, we thank you for your participation, and it's been our pleasure to bring this to you from the Institute for Health Equity Research. Wishing everyone a wonderful holiday season. There are some people who are actually invited to another session with Dr. Beach that is on a different link. You know who you are. And thanks to everyone, and happy holidays to all, whatever holidays you may celebrate. Thanks.
Thank you.